Okay, I think we're almost 5 past the hour, and so we're going to go ahead and get started. I know we have a smaller group today, but hopefully we'll get some others that join us along the way. So I would like to welcome you all. My name is Emily Hirata, and I'm the chair of ADRA's Health Technical Learning Lab. I would like to welcome you to our webinar today on impact verifications and assessments that were conducted on community nutrition, facilitation, and rehabilitation projects in Laos, PDR, and Cambodia. We're very glad that you could join us. Before we get started, there are just a few housekeeping announcements. This webinar is being recorded and will be uploaded to the ADRA Technical Learning Lab YouTube site after it's finished. So for anyone who would like to view it later on, or for those that weren't able to join us today, it will be there. All mics will be muted except for those that are presenting. However, if you do have questions, and we do encourage questions, please feel free to post them in the chat. I know there might be a Q&A box that shows up on your screen. Please do not use that. Please use the chat. And we will, if we have time at the end, which we have planned on, we will try to get through those questions. Something to note is that this is the first time that our Health Technical Learning Lab is using Microsoft Teams as a webinar platform. And while we do not anticipate any problems, please do bear with us as we navigate this for the first time. With all of that said, I would like to hand it over to my colleague, Porm Keosamon, who is Program Manager with ADRA Laos, to set the scene for us and to introduce our main speaker. Porm, please take it away. The time is yours.
Right, thank you, Emily. And I'd like to welcome everyone again. And so good evening from Laos. It's evening here. So before I hand it over to Mr. Kachro, I'd just like to tell you a little bit, provide you with the background of this presentation that we will hear. So ADRA Laos and ADRA Cambodia both are recipients of the CFGP Foodgrains funding, and so we have similar experiences, and also implemented similar projects. So for Laos, we have over 3 decades of experience in multi-sectoral approach for integrated nutrition-specific and nutrition-sensitive interventions, and also community-based approach. So in the past decade, we have seen significant success in our interventions. And for nutrition-specific interventions, we employ what we call community nutrition rehabilitation program for children under 5 and also under 2, and of course women of reproductive age, and also vulnerable household. And then we have sensitive activities in livestock and also crop production, and also climate smart agriculture. And similarly in Cambodia, so Cambodia is also strong in health and nutrition, and also non-communicable disease and human development, and also rural climate resilient livelihoods projects. So the projects in each country, in a sense, focus on food security and agricultural production, and also climate change challenges, and that's all integrated in health and nutrition and WASH interventions that we have. So for Laos, we have finished 2 projects. We call it Enhanced Nutrition and Health for Upland for Good, Phase 1 and Phase 2. And then in Cambodia, the recent project is the Beret Santuk Nutrition for under 2 and mothers. So since ADRA at ADRA as a network and also ADRA Laos and Cambodia. So we are committed to learning, and we feel that based on these successes and uniqueness in our approach, we think that we can share this and we can learn from this and learn from each other and also learn from other countries. So that's why we have Mr. Cultural to conduct an impact assessment. And so the assessment took place in August. And then with the report ready, and so and this presentation today. So, but allow me to tell you a little bit about Mr. Koichiro. So, Mr. Koichiro is a very experienced man, and he has a master's degree in public health from the U.S. and also a master degree in rural and social development, and also a bachelor degree in agronomy. And so he speaks 4-5 languages, and including Japanese, Vietnamese, Chinese, and English. So this is new to me. And Mr. Koichiro, I would say, is a professional consultant. So he has conducted a lot of consultancy services in many parts of the world, including Papua New Guinea, Ethiopia, Nigeria, Myanmar, Tanzania, and Laos and Vietnam. So and mostly in nutrition. So we are very happy that he took the call and has been working very hard to collect the data, to analyze, and also to produce the report and so prepare this presentation. So with that, I'd like to thank Mr. Koichiro and also to hand over the time to you so we can get right into the real thing that we are here for. Thank you.
So can I start?
Yes, please.
Okay, so thank you very much for your introduction, Mr. Pong. And also this is my great pleasure that I'm invited to this event and also have opportunity to work with ADRA. This is my first time to work for ADRA, and it has been quite interesting and quite important experience for me. So I did this work titled Impact Verification of Approach Assessment of ADRA's Community Nutrition Rehabilitation Project in 2 countries. So I'm a nutrition consultant, but right now I'm also head of my own NGO called Network for Action Against Malnutrition. So this is the picture of the 2 countries program, and unfortunately I couldn't visit Cambodia program, but I took this photo from the report, and then the right hand photo was the one I took in Xiangguan. So purpose and method of this assessment work is to identify the distinctive impact of the 2-country approach in Laos and Cambodia, so that it can be compared and then contrasted. More specifically, I was asked to analyze the statistical result of the data, and also I reviewed, understand, and document the unique feature of the 2 countries approach, and also to identify challenge and opportunity. And more importantly, I was asked to propose kind of consolidation of the 2 approaches, and finally to assess the climate change gap, adaptation, and resilience actions. So I started from, I think I started in June or May, started from desk review, reviewed all the baseline survey, end-line survey reports, project annual reports, proposals, other technical document, and secondary data. I did interview with the other Laos country director and Mr. Pom and other people in the Vientiane, and I also visited Xiangguan province to meet with project staff and the stakeholders and I did interview with the key people at the district, provincial, and also community level, even the beneficiaries. I did also observation of some of the project activities and some materials used. So before starting the result of the assessment, I'd like to highlight some limitation. So of course, impact of COVID-19 pandemic was quite large for the project activities and outputs. So we need to also consider this element when you look at the results. Very limited time and scope of the assessment. I could only visit 1 week, very short field assessment in Laos, and also I couldn't visit Cambodia. So most of my study was based on the literature review and the secondary data. Most of the impact verification was based on the annual surveys that was carried out in the 2 countries every year. So this is very good, comprehensive data collection, but it was only done baseline and end of first year, second year, and third year. So there was no data collection of the control or comparison communities or area. So when you do the interpret the result of impact, it is only based on the difference between baseline and end line. So that also should be kept in your mind when you interpret the result. So I think most of you are already familiar with this chart. This is called UNICEF Conceptual Framework of Malnutrition. So it is illustrating the different causes of malnutrition. So at the immediate level, I would use this. Okay, so at this immediate level, there are 2 direct causes. One is inadequate dietary intake and diseases. So those are individual level, most immediate causes of malnutrition. And below this level, we have 3 underlying causes, which are household food security and care and feeding practice, and also access to health service and sanitary environment. So those 3 underlying causes are mostly at household or community level, and it is very important factors, particularly for prevention of malnutrition. And below that level, we have many other social level or national level factors that is kind of basic root causes of malnutrition, like lack of low level of education, poverty, lack of resources, human resources. So those 3 levels of causes. So when we design any project intervention, as much as possible, we should look at the different part of these causes and to address them, so that it has to be, and it should be multi-sectoral comprehensive nutrition program. So I just showed this framework just to highlight that the 2 countries nutrition program actually included several 1, 2, 3, 4, 5, 6, 7 kind of component, which were addressing the different part of these causes of malnutrition, so that I think in terms of design, it's quite relevant and addressing comprehensive factors. So at the individual level, the 2 country program include the nutrition rehabilitation for acute malnutrition. Also, 2 country program include the community disease prevention and WASH, which addressing this part. And for this care and feeding practice, they have community nutrition learning component for behavior change. And for household food security, also the 2 countries program included the home garden, and in Laos it also included livestock. And also gender was main part of the program, and also it included the system strengthening and governance capacity building. So those are kind of broad illustration of the conceptual framework of the program. And if you look at more deeply in the household food security, because this program is funded by the CFGB, Food Grain Bank, so this is more in-depth kind of theory of change within the household food security, and to which we need to address the availability of the food access and also utilization. So those are integral part of the two countries program. So first thing I did was to illustrate the kind of results framework and compare the two countries' result framework and see how they are different or similar. And this left-hand side is the Laos kind of result framework. This is intervention, immediate outcomes, and intermediary outcomes. And this part is for Cambodia. So again, this starts from intervention, immediate outcome, and the intermediate. So as you can see, this different color illustrate the different component of the project, which I already explained in the conceptual framework. So quite similar, as you can see, the two country program include the most of the key component of the project. Slight difference in a way that for example, for the household food security of Laos program, this green part is more separate, independent component, whereas in Cambodia it was integrated within the rehabilitation program. On the opposite side, the Cambodia program has set the gender component as a kind of standalone component, whereas in Cambodia it was kind of integrated within the community rehabilitation and other component. So those are the illustration of the two kind of theory of change. But again, what I want to say is the two countries are quite similar, and try to change the communities. One more big difference was in Laos included the interventions for adolescent girls because of the life course nature of the malnutrition. It is increasingly aware that the adolescent girls' health and nutrition is the very important cause of malnutrition. So that was the new element included in Laos. So later on, I kind of, in the recommendation, kind of consolidated the two countries' approach so that it looks like this one. So I'm not supposed to go too much in detail, but what you can see is this is the kind of recommendation that I highlighted in the report. So before explaining this in detail, I'd like to now compare how the two countries' approach for each component are different, because overall design are quite similar, but within each component, how they implemented those components are quite different, which is quite interesting. So again, I'm sorry for this very small font size of this slide, but this table explains the Laos and Cambodia, the key feature, how the interventions are implemented in different components. For community nutrition learning, which is for behavior change, for infant feeding and child caring, mainly Laos are used in community sessions where the people are mobilized in each village and people gather, and facilitators provide some key messages, and then the kind of the discussions on the topics. Whereas in Cambodia, it is called reflective circle methodology, which is a unique, innovative method of grouping the women, men, and then children, small group organized in each community level, and then they facilitate key topics, topic by topic. So this is kind of interesting difference between the two countries. Adolescent intervention, it was only included in Laos, as I already explained. Nutrition rehabilitation, this intervention, quite similarly, the two countries used the positive deviant Haas approach together with growth monitoring promotion. So they weighed all the children under 3 or under 5, and identify the underweight children who are registered, enrolled in the PDR program, where they cook, learn how to cook food, utilizing locally available food, and also feed their children for 12 consecutive days. Later on, the Laos program, it's modified a little bit to shorten the number of days. In Cambodia, because of the COVID, it's quite difficult to implement this key intervention part, but they also adapted this model by using more home visit approach. So there are some other key difference, but another key difference of this component is in Cambodia, they targeted all the children, whether they are malnourished or healthy. They measure every two months, whereas in Laos, they more focus on the underweight children to enroll in the growth monitoring. So home garden livestock, the main difference is, as I already told you, in Laos, they conducted training, input distribution, and support monitoring. They also promoted animal bank system for sustainability and veterinary training. In Cambodia, also they more focus on specific vegetable which is rich in particular micronutrient, like iron-rich kind of vegetables, and they are integrated as part of PDR program. So slight difference in the two program. Okay, gender session, quite interestingly, the approach are different. So in Laos, they organized community learning session and discussed gender issue. Also, Laos program promoted kind of gender equity, gender-based violence kind of campaign, and also advancement of women. So there are some innovation activities they included. Whereas in the model of Cambodia, they use this reflective circle methodology and discuss the gender issue within the female group, but also within the male group, but also male and female together in a small group session. And the topics were integrated into nutrition practices. So, for example, how to decide which food to purchase daily basis, and this kind of topic, very practical gender topics are discussed between women and men together. I think which was quite an interesting approach and innovation, and it also should be quite effective. So in terms of community disease prevention, the two-country program both included two main subcomponents. One is promotion of practice for prevention and treatment of nutrition-related diseases. The other was for promotion of WASH. So main difference between the two programs is in Laos, it's quite similar, but difference is in Laos, they're more based on the approach called community-led total sanitation, which is kind of methodology for sensitize the community people about the risk of open defecation and the needs of sanitary facilities through different tools and discussions. So it was quite successful in Laos to promote the awareness about the importance of hygiene, sanitation, but also it created the demand for the sanitation facilities. So it was quite effective approach for demand creation. As compared to Laos, in Cambodia, they are more different, use different approach, more focus on the using the private sectors and promote the purchase of water treatment equipment and sanitation facilities by providing the kind of voucher system. So it was more successful in terms of the supply side of wash intervention. So both programs are slightly different, but they are effective in different parts. Finally, system strengthening governance. So the Cambodia program more focused on documentation and the experience sharing. And also some establishing village committee for advancement of women, kind of community level structures. Whereas in Cambodia, they focused more specifically on the nutrition surveillance system establishment, which is also different focus. But together, they are contributed to the system strengthening and capacity building. So I'd like to now show some graph, which is the illustration of the, I would say not impact, the difference between baseline and end line for the different countries. And first, this slide is about knowledge and practice related to nutrition and health. So you can see this is the baseline, and the black one is the end line. For this is Laos, and this is for Cambodia. So both countries, you can see clearly the improvement of knowledge and practice related to the health and nutrition, feeding practices, prevention, treatment of diseases. But this one is more, I highlight this one is in Cambodia, it is about the household level decision-making, joint decision-making indicators, so which was quite significant improvement. It was in Cambodia, you can see. So now this one is more specifically the other outcome on food security and WASH. So in terms of food security, the upper hand, the two graphs shows the improvement for different indicators in Laos. And you can see clearly the very big increment in the proportion of households who have access to vegetable and animal sources, and also diversification of the diet and even frequency of feeding children. The quite significant, looks quite big improvement was observed. Whereas in Cambodia, I observed more significant increment for the WASH indicator, access to latrine, and then access to water, safe water. You can see the quite big improvement for Cambodia. So finally, this is the nutrition impact level indicators for wasting, underweight, and stunting, and for boys and girls separately. So you can see clearly the big improvement of underweight in Laos, whereas this improvement was not so clear for Cambodia. I think because of the COVID-19, negative influence was more in Cambodia, and because of that effect, food security and access to services were quite limited. That was one of the potential explanation. But more importantly, in two countries alike, as compared to underweight, the impact on stunting, although we can see some improvement for Laos, it is more take more longer time as compared to underweight. Therefore, in order to verify the actual impact on stunting, I would suggest that you conduct kind of another survey after 2 or 3 years. That should be quite interesting research that you may invest. So apart from nutrition impact, there are some other important impact and sustainability issue. One of the most important the finding was that both two countries' program strengthened government partners, and they earned practical knowledge and skill, which can be applied in their own routine health and nutrition services, such as growth monitoring, home visit, and management of acute malnutrition. So because of the experience they participated and training they received from the project, after the project, we can expect that their services will be, the quality of their services will be improved and sustained. They also, the two programs both focused on the behavior change as key component. So I think it's quite important for the sustainability, because behavior change can be sustained even after the project stopped their intensive nutrition promotion activities. Still, the improved behavior can be sustained at household level. So those are some of the impact, sustainability, and finally there was some imitation and the challenges for Laos. Sustainable behavior change in severely poor household was more difficult, and the lack of access to market, particularly remote village communities, and also COVID-19 pandemic, which limited access to communities. I think in Cambodia also the similar experience, but more COVID-19 pandemic influence was quite big for mobilizing the people and access to the services. So having said that, this is my last slide for the consolidated framework. So what I can describe in the report is more detailed step-by-step instruction of the different steps, but because of the limited space in the slide, I only highlighted the key component. So what I highlighted here is it is most important that any program design is based on the situation analysis, because each country, each locality has different cause of malnutrition. So we have to do the very careful situation analysis, then based on that to design the program. Particularly, I highlighted here the importance of formative research. Formative research is kind of research to understand the reason why people do not change particular behavior, such as exclusive breastfeeding or complementary feeding. Not only the quantitative survey, we need more in-depth interviews in the community to understand the barriers and enabler of the key determinants of the behavior. So based on that, you can develop the key messages and communication channel of different key messages. So this part, not only Laos or Cambodia, in Africa, everywhere, this is a key to the success of the successful program design. And based on that, you can design the program implementation component, which can be selected from the successful experience from Laos and Cambodia. Each component has different pros and cons of the two countries. So I would not say this part should be taken from there, where, or this part should take from there. But importantly, we can look at the different strengths and challenge of the two countries' experience in each of the component, and to use the most appropriate intervention for each of the component. So those are the very short presentation, and I think I exceeded my time already. So sorry for the very poor time management. Thank you.
Thank you very much. That was a very insightful presentation, and I know for our guests, I know we're only here for an hour together, so we can't get into a whole lot of detail. But I do want to thank you, Mr. Koichiro, for that insightful presentation. I would like to move us directly into our Q&A. I did see a couple questions in the chat, and I do have a few questions that came in privately to me as well. But first off the bat, we did receive a question about receiving a copy of the presentation. We will send out a recording of this to everyone who has registered, and we can also include a copy of the slides as well, if that would be helpful for people. But back to the presentation, the first question we received was there an intention that the two country programs would interact in discussing implementation, learning from each other, etc.? And if so, how did that happen?
Maybe this should be, as long as I know, there was some interaction, but maybe Mr. Pom can answer this question more detail.
Yeah, okay. Yeah, I can take that question, and maybe Cambodia can add. So we have I had a program advisor who oversaw the two country. So that was Suraj, and who was working for ADRA Canada. That and then sitting here in ADRA Laos, and also supporting ADRA Cambodia and also Mongolia, I think. And so in the sense, we had meetings a few times, but we share resources, and also Suraj was able to talk to Cambodia, and then also learn from Cambodia how they were doing, and then advise the Lao team here, our team here. So, but then project. So we had very limited interaction, but in a program level, we have someone bridging the gap, I would say. Yeah.
Yeah, Mark here from Cambodia. I think, yeah, Pom was pretty correct in his analysis there. I think the main thing was that Suraj's more close connection between the two projects did not actually start like before the project or even right at the very beginning. So yeah, there was not a lot of co-design at that particular point in time, except through Avish and others from ADRA Canada who were supporting us in the design of the two projects. Thank you.
Thank you all for that. The next question we have is, how long was the nutrition intervention in both countries?
I think it was for this object of this study. It was 3-year project in both two countries. But before that, the two countries also the previous phase, which was also another 3 years, I think. If I'm mistake, please correct. But they are different target area, I think.
Yeah.
Yes, that's right. And so as I mentioned earlier, so for ADRA Laos, we had phase 1 and phase 2 of this project, and so the impact assessment was done during phase 2 at the end of phase 2. But before this project, ADRA Laos also had not specifically nutrition project, but a component of nutrition project in nutrition in our other projects in Laos. Yeah.
Great, thank you for that. The next question is, what was learned about the different approaches to targeting for nutrition rehabilitation between the two projects? For example, Cambodia reaching all children regardless of nutrition status versus Laos targeting underweight children. And do you think this had an effect on nutrition status outcomes?
Yeah, it's very interesting question, but as I already explained, in terms of the PDR design, it is quite similar. Only difference I observed was the targeting of growth monitoring promotion, and the number of days for PDR in Laos, it was shortened in the middle of the project from 12 days to 5 days. And instead of continuing another 7 days, they provide the food ingredient to the household, and then they visit their houses to monitor so that they continue the PDR at home. I think it was one of the innovation, quite interesting and quite also effective. I didn't visit Cambodia program, but I think the design was quite similar. Yeah, that is my observation.
Yeah, maybe I can add to that. So the program in Laos is still 12 days, and but however we learning from phase 1. So because in Laos the project team cannot just go and conduct the activities by themselves. They have to take health staff or government staff with them, and the government staff were complaining about long days in the communities, and so we cut that short to 5 days. That means the team, the project team, project staff, and the government partner would conduct the activity in person for 5 days, and then after that handed it over to the village health volunteers and Lao Women Union, and that were trained to continue the program until the end, and then until day 12, and that's when the project staff would go there and to monitor the progress or the weight. And so also the children that were registered in the program, not just underweight children, but also wasted children, and so basically malnourished children under 5. That's the core target group in the community rehabilitation program. Yeah, thank you.
Thank you. What were some of the key factors that contributed to the great successes observed in the two countries? Overall, the positive changes are huge and very commendable. So what were some of those key factors?
That's a very
Emily,
interesting question. Yes.
Can I just make a comment before he responds?
Yes, go ahead.
I mean, this is the first time I'm seeing these huge differences in any program. A program that can increase the knowledge of women and men by 60%, like between baseline and endline. And both programs did make differences that are very significant and difficult to achieve in most programs that I have worked with, like reducing stunting by 8%, reducing between baseline and endline, reducing stunting by almost 10%, and improving food security by 30%, improving dietary diversity by 20%. Those are big achievements. And given the duration of the project, which I had was around maybe 3 years, those are quite commendable achievements. So I'm just curious to hear what do you think are some of the key factors that contributed to such huge achievements? Thank you.
Okay, for my side, I'd like to say two things. One is in terms of the limitation that I explained in the beginning. This is the only comparison between baseline and endline, and also the sampling strategy of the nutrition survey. I'm not really able to access to the sampling strategy. So, in a strict sense, as a researcher, I cannot say compare the two proportion without knowing the sampling strategy, and even the statistical test or confidence interval we cannot figure out. So this is kind of the just still comparing the secondary data conducted in the beginning of the survey and the end of the survey. Still, but I observe a lot of improvement. So as you can see, in terms of the knowledge, huge improvement for feeding practice and disease prevention and treatment. But interestingly, for disease prevention and treatment, the improvement in the knowledge and practice doesn't translate it into the prevalence of the disease. I didn't highlight it in my presentation, but perhaps because there are many other factors affect the disease morbidity, which were not completely addressed by the project. So disease prevention and treatment, although the improvement in the prevention and treatment, it doesn't improve the disease prevalence. That means the factors to improving the nutritional status maybe come from other factors, such as household food security is one factor, in particular in Laos. And for Cambodia, I would say the largest improvement was in gender equity and also the WASH. It is quite a remarkable improvement. So it is very difficult to say which factors contributed to which outcomes without doing more statistical examination, which is not possible from my side, but this is my kind of observation.
Yeah, thank you, Koichiro. And so currently I am analyzing the end of project survey data, and without getting into the specifics, the technicality, maybe I can provide more contextual factors into what our project in Laos. So we have phase 1 and phase 2, so in the same district, and but in phase 1, so 3 of the villages out of 16, 3 were not doing very well, and so we included those 3 in the new in phase 2 as well. And then there has been a lot of improvement in knowledge and practices in those 3 villages. And so another factor is that we also have a food security project. So basically, we, in a sense, integrated these 2 projects. So so the food security project also picks on the also target the household with children, with malnourished children. So we also that's how we selected the some of the target beneficiaries or household for our food security project. So, and then what's left from that project is what NHAP or our nutrition project food security component addressed. And so that means, in Laos, in the case of Laos, so we have to, another important factor where we have a food security project running in half of the 60, half of the target villages, 8 out of 16. And so the food security project, also support home garden and also livestock raising, and to increase the food consumption and production and consumption. So that's, I think, a relevant factor here. And when again, yeah, personally, when I look at stunting, and I'm also surprised, the rate of stunting went down by looking at the data, and but I think it's it's something to celebrate, and yeah, there can be error there, but there's a decline and a reduction, so that's something that we are happy about. Thank you.
Thank you for that. As a follow-on question to that, you mentioned limitations. In light of these limitations, what do you think was needed to improve data collection and to reduce those limitations?
Yeah, what I would suggest is for any impact, if you really want to impact the study, ideally you can use the external institution who are not part of the project and use the statistically rigorous research design, such as including the control community and for baseline and end line. Well, but which is very expensive and normally it's not so easy to practice. But if you really need very strong evidence, that is one option, I think.
Great, thank you so much. I know we're running out of time, so we'll just try to take one or two more questions. The next one in line is, what do you think that Cambodia has, or why do you think that Cambodia has a low rate of improving malnutrition compared to Laos?
Yeah, that was I already explained. My observation is because of COVID-19, which seriously affected the implementation of community nutrition rehabilitation activities. So also, I don't know because you don't have the control, I don't know the overall food security status in Cambodia might be worsening in general. So that could be but maybe Mark can have other observation.
Yeah, I can just share that over several different projects using similar designs, I guess, using the reflect circle self-help group models. We've had varying results in different situations. It's a fairly intense project, though it's still a volunteer project as far as people coming to the actual group and whatnot. So the amount of contact time with any individual caregiver and their children can vary. And of course, the survey has some random errors, sometimes from baseline, like going to intermediate annual or intermediate surveys to inline. You'll get some fluctuations that are very difficult to figure out. But another factor, I don't know really much about the Lao context. Looking at some of the traditional dietary practices, we find that sometimes while you may be able to improve knowledge, even like you were mentioning in the WASH area, you may be able to improve knowledge about what you should do, but actual practice may be a little bit different. We also experience, so in let's say feeding practices, we know a lot of malnutrition is caused actually more by disease. A child gets ill for periods of time, and that leads to them losing weight over a period of time during periodically or whatever. But sometimes the significance of change of feeding practices is not as much. And one indicator that you didn't mention, because it probably was not one of the highlights, is actually the infant and young feeding practices, which it combines several different factors, including breastfeeding, which, because mothers nowadays are quite migratory, A lot of them are traveling away from their homes, leaving their children with grandparents or aunts and uncles and whatnot. So there's those types of factors that sometimes the people that are involved are not necessarily translating to the exact practices of the actual caregivers of the children. So there's a lot of complex factors, at least in the Cambodian context. Yeah, and we, in this particular case, did not see some of the results that we would have liked to, particularly in the actual changes to the nutritional status of the children themselves.
Thank you so much to you both for that. My apologies, we will not be able to get through the rest of the questions because we are right on the hour. I do want to thank you all for joining us. I especially want to thank our presenter, Mr. Koichiro. Thank you so much for the presentation and for the work that you've done. Thank you to ADRA Laos and ADRA Cambodia for these wonderful projects that you are doing, for all those beneficiaries out there that you are working with. We hope everyone that has attended this has gained some insightful learnings. In the coming days, you will receive an email with a recording of today's webinar, as well as a satisfaction survey, so please be on the lookout for those. We will try to also include the PowerPoint slides from today, as well as the report that this is based on, if that will be possible. So please be looking out for that. And with that, I would like to thank you all once again for your participation. We wish you a warm farewell for the rest of your morning, your afternoon, or evening, wherever you are. Thank you again. Goodbye.